Trauma therapists ask me this question all the time. Which trauma treatment should I get trained in? And I know the internet makes it seem like if you don't choose the right trauma treatment, you're just going to be a big old failure as a therapist, right? Well, today I'm going to dispel all that shit because the stories we're told in therapist Facebook groups create way more anxiety than clarity. And when I get this question or I see it in a post, what I often notice underneath is a lot of pressure. Pressure to choose the approach that's going to be the most effective for your clients. Pressure to choose something that's recognizable and marketable. Something that sounds credible when you put it on your website or say it out loud to your colleagues. And pressure to not make the wrong choice with your time, money, and energy. Because trauma training isn't a casual decision. These trainings are damn expensive. They take time and emotional bandwidth. And once you commit, it can feel like you are locked in to a path that you can't undo. Oh, wait, real quick. If we haven't met before, I'm Dr. Jenny Hughes. I'm the founder of the Brave Trauma Therapist Collective. And a big part of my work is supporting trauma therapists as they navigate career decisions like this. They ask what to get trained in, how to grow sustainably, and how to stay connected to their own humanity while doing this really deep and amazing work. So, as we get into this topic, I want to hear from you real quick. What trauma treatment are you thinking about getting trained in right now? Go ahead, drop it in the comments for us, because this question isn't really just about training, right? It's about wanting to be a good therapist, whether you identify or call yourself as a trauma therapist or not. This is about wanting to help people well, and it's about trying to make smart decisions inside a system that doesn't give us a lot of guidance on how to choose. But before we talk about any specific trauma treatments, there's something super important that gets missed in almost every single one of these conversations that I see online. Across all these different trauma approaches, the therapeutic relationship and attunement are key. No model bypasses that. No protocol replaces it. And when we forget about it, training decisions start to feel way more high stakes than they actually need to be. And I want to say this. I didn't strategically set out to collect trauma models like I'm collecting my Pokemon 15 years ago when I started to be trained as a trauma psychologist. My path into trauma work unfolded through real work with real people. That's what shaped how I understand this question now, okay? So, which trauma treatment did you put in the comments? Put one there if you haven't done yet. And I'm willing to bet it's one of the following: EMDR, Brainspotting, cognitive processing therapy, prolonged exposure therapy, accelerated resolution therapy, somatic experiencing, or internal family system / IFS. Whew, that's a mouthful, and it's not even an exhaustive list of all the trauma treatments that are out there, but those are typically the most talked about and most marketed options that are out there. And many of them have a really strong evidence base, and none of them are inherently bad choices. But naming them isn't the same thing as helping you decide, right? So, to answer your question, and I am going to get there, but I'm going to take a different route than any specific recommendation for a certain modality, because I want to help you think about how to evaluate these trauma models. And we're going to do that through 3 lenses that I want you to hold in mind as you listen. First, how structured is the work in the modality that you're looking at? Some models have super clear protocols and steps, while others are more flexible and responsive in the moment. The next lens is, where does most of the processing live? Is it mostly cognitive and top down, or somatic and bottom up? Is it relational or parts based, or somewhere in between any of this stuff? And the third one, and this matters a lot, what does this modality ask of you as the therapist? How much emotional presence does it require? How much intensity do you need to tolerate as you do the work in this modality? How comfortable are you in sitting with uncertainty? most training conversations skip this part entirely, right? People are not picking them apart and evaluating them in this way. And that's a problem because fit of the trauma modality matters for your sustainability and effectiveness depends on whether you can stay regulated, present, and human in the room. And that's going to be different for everyone. For someone for whom CPT is best is going to be different than someone for whom Brainspotting is best. And none of that is set in stone either, okay? But hold these three lenses as we keep going and talk about which of these most popular trauma treatments fall into some different groups. Okay, so we've got three lenses and then three groups. Group one is what I consider to be these highly structured and typically cognitive heavy approaches, like, as I mentioned, cognitive processing therapy and prolonged exposure therapy. These models have super clear protocols. They're highly structured, they have strong evidence bases, and for many therapists, that structure can feel real grounding and containing, especially early on. My own first formal trauma training went along this path. I came up through academia. And so I was first trained in TFCBT with kids and then added on DBT. And later, as the trauma psychologist at a level 1 trauma center and in academic settings, I spent years doing CPT and PE. And this work absolutely helps clients. And it can also place heavy cognitive and emotional demands on the therapist. We are hearing and experiencing so much of the trauma work in tandem with the things that our clients are telling us in these modalities. The relationship is totally still present in these interventions, but it's not always necessarily centered in an explicit way, especially in the way that they are trained. And because, like I said, these approaches ask us to hold lots of detail with our clients, that might be fine for some therapists out there and not for others. So it's just being honest with yourself about what your brain and body prefers in this moment. Okay. The second group we're going to think about are those trauma therapies that take a structured approach to reprocessing and integrate a lot of relational flexibility. So this includes EMDR and accelerated resolution therapy, approaches that still have lots of structure, but allow much more flexibility in the moment, especially once you've been practicing them for a while. Because when they're trained, you stay really, really close to the protocol. And then as you internalize it, you learn how to be flexible and what ways can you be flexible while still being true to the approach. These kind of interventions are often less verbally heavy for clients and therapists. And that can be really helpful because we're not taking in as much of the explicit detail of what our clients are working on. They also require the therapist to track attunement very closely, not just tracking the protocol. Okay. Now, for me, I trained in EMDR during the pandemic, and I worked hard to advocate for being able to use it in the trauma clinic where I was working. I wanted to get that stuff in action. And that experience, going from this super structured CPT and PE to also then being able to do EMDR, brought me back to my relational roots in a new way, the relational way that I was trained coming up as a young psychologist. The structure didn't disappear from my CPT and PE work or from the EMDR I was doing, but the relationship became much more visible and intentional in the work, which for me was a wonderful fit. But you have to ask yourself that question too, okay? Now, group 3 includes approaches that are super relational, somatic, and may even include parts-oriented work. And these are things like Brainspotting, Somatic Experiencing, and Internal Family Systems, or IFS. Now, these are, as you know, I've said, deeply relational and these bottom-up approaches. And they ask a lot of therapist presence and require you to be able to sit with uncertainty and really track what's happening in the room. And they can also decrease the impact of trauma details on you as the therapist because the client doesn't necessarily have to share much or anything of what they're working on. I've had brain spotting sessions where we are essentially silent for almost 50 minutes and the client made so much progress through that attunement and the focused mindfulness. Now, speaking of brain spotting, training in that modality deepened my understanding of somatic processing and naturally introduced parts work into my practice. And I fell in love with it immediately. And while it has certainly changed my practice overall, I haven't abandoned my earlier training. Rather, I've integrated all my years of experience so that I can meet the varied needs of my clients. And this is honestly how I usually present it to my clients, as a menu of options, a spectrum of options where they can choose to do something like CPT with me and be super structured. They can move into some EMDR and have some structure and some flexibility. And they also have brain spotting, which is super unstructured and flexible. And I often will even integrate all of those back and forth, right? So again, it's not about picking the right or the perfect trauma treatment, but thinking about what are your brain and body's preferences? What are the kinds of clients that you love serving? And what is going to be most beneficial for you in your relationship with those people? Okay. When we think about all of these treatment modalities, I haven't really talked about the evidence bases for them because I encourage you to do your own research on that. They each have their own research base and bodies of research being conducted alongside it. And, of course, the cognitive approaches are going to be so much easier to evaluate than the less structured ones. But do your due diligence as you explore each research base in your process of deciding which training to take. And share really great resources here. This is a wonderful thread to start collecting the research on these different models. Okay, before we end, we also have to talk honestly about marketability of these trainings. Because yes, some models are more recognizable. EMDR is becoming more of a household term now. Yes, acronyms matter when clients are searching for care, but clients don't heal from acronyms. And even as some of these are becoming household terms, most clients are not searching for therapists in that way. So, also, as we move into the future, the kinds of trainings we have is going to matter even more because protocols can be replicated. Cognitive processing therapy can be automated, but an attuned, regulated human relationship can't be replaced. Watch my video on my predictions for AI in 2026 for more on this, because when I'm talking about these things being automated, I'm of course talking about AI doing it. And when we're thinking about models being automated or the future of them or their benefit for your practice, none of this is going to be model specific. For me, when I look back at my own career, like I said, my path was not linear or strategic. And I didn't abandon trainings as I evolved. Everything I learned built on what came before. And the through line was always the same. It was the relationship, the attunement, being a regulated human in the room. So, yeah, training matters, but no model replaces being human in the work. No model guarantees you confidence or sustainability in your practice. And no model should be chosen in isolation. This is actually something we talk about all the time inside the Brave Trauma Therapist Collective. We have members who are brand new trauma therapists or even still students and haven't had the chance to take advanced clinical trainings in any trauma specific models yet. We also have really seasoned therapists who already have multiple certifications and are trying to decide what, if anything, they want to add next. Those conversations look different, yes, but the core questions are still the same. How do I grow without burning out? How do I make thoughtful training decisions instead of reactive ones? And how do I stay connected to myself while doing this amazing work? What makes this conversation so powerful is that when we're talking about this stuff together in Brave, no one's trying to convince anyone of the right model. We're thinking together. We're contextualizing the training, and we're holding the truth that your effectiveness as a trauma therapist is shaped just as much by the support, reflection, and relationships that you have as it is by the actual technique. So if this video is speaking to you, maybe you're feeling stuck, unsure, or pressured to get this decision exactly right, you don't have to figure it out on your own. You're allowed to take your time. You're allowed to grow over the course of your career, and you're allowed to ask for help. So reach out. I'm here, Brave's here. Seriously, I mean it. How can we help you when you're asking yourselves these super important questions that matter for your clients and for you?